Your passcode has been confirmed. If you need technical assistance during your call, please press star followed by 0. After the tone, please state your name. Thank you. There are 25 parties in conference, including you. This conference is in silent mode.
Star 6 to individually unmute your line at the time of asking a question. And since we can't see who actually wishes to ask questions at the end, I'm going to ask you to electronically raise your hand after the presentation if you wish to speak. In order to do that, you need to click on the Q&A tab on the menu bar of your webinar screen. And then once you're in the Q&A window, click on the hand icon in the upper right corner. This will display your name to the meeting presenters. And so I will call on participants as their names are displayed. Once your name has been called, please state your name and affiliation before asking a question or providing a comment. You can raise your hand during the presentation, but we're going to wait until the discussion is finished to address these comments. I also would like to let everyone know that today's session is being recorded. So with that being said, I would like to introduce today's topic, the use of hydroxyurea for sickle cell disease. And our speaker is Dr. Nancy Green. Dr. Green is an Associate Professor of Pediatric Hematology at the Columbia University Medical Center, Associate Dean of Clinical Research Operations, and Associate Director of Columbia's Clinical Translational Science Award. Dr. Green is board certified in Pediatric Hematology Oncology. She has a broad background in laboratory and clinical research. She previously served as Medical Director of the National March of Dimes, and her research focuses on clinical translational aspects of sickle cell disease and on population-based genetic testing. So at this time, Dr. Green, if you can unmute your phone by pressing star 6, we can go ahead and get started. Dr. Green, are you there? Again, it's star 6. Dr. Green, we can't hear you, so we'll try and get this fixed on our end.
Let me ask you that.
Hello? Can you hear me now?
Yes, we can hear you.
Okay, I'm sorry.
That's okay. Go ahead.
Okay, may I start now?
Yes, please do.
Okay, well, thank you to the Division of Blood Disorders at CDC for inviting me to speak about sickle cell disease and for participating in this really terrific series of webinars on important issues in blood disorders. So as you've heard, I'm going to speak about hydroxyurea for sickle cell disease. And could I have the next slide, please? Okay, and just a standard disclosure that I have no financial conflicts of interest, but I will be speaking about an off-label use of hydroxyurea since it is not FDA approved for use in children. Thank you. So the outline of my talk is as follows. What is hydroxyurea? What does it do? How does it improve sickle cell disease? What are the indications for its use? What are its limitations? And in particular, focusing on toxicities, sickle cell subtypes, and barriers to use. And what is its future potential? So just to say that the majority of this presentation will focus on hemoglobin SS and hemoglobin beta zero thalassemia, S-beta zero thalassemia, as the major subtypes of sickle cell disease for which there are clinical study data on hydroxyurea. But I will be addressing some of the other subtypes later in the talk. So this demonstrates a curve that may be familiar to many of you. It's the perspective from mortality of sickle cell disease in the U.S. starting in 1979, where early mortality was not uncommon. And then with the advent of universal newborn screening, penicillin prophylaxis, good interactions with families, et cetera, the mortality rates shifted to older ages. But in stark contrast, the black line shows in 2006 the trajectory for African Americans with hemoglobin AA, and obviously very, very different life trajectory. So this is just to say that there's obviously a lot of room to improve, and we don't know on a population basis what the impact will be from hydroxyurea, but I hope to sort of ask some of the questions and present a somewhat optimistic view of that. Okay. So just to remind everybody that sickle cell disease is not just anemia or pain, although those are obviously the most prominent features of the disorder. There are both acute and chronic aspects of sickle cell disease that really affect every organ system. And the photo on dactylitis serves to remind me to just describe that kind of the most visible manifestations of sickle cell disease. The most visible manifestations of sickle cell disease are swelling and pain, underscoring the inflammatory aspect of what we call crises, but remembering that the chronic organ dysfunction also really indicates that people are not necessarily well in between crises, and we'll talk about that later in the talk. Okay, next slide, please. Thank you. Okay, so in normal red blood cells, hemoglobin is a soluble protein, but in sickle cell disease, the sickle globin forms long, inflexible polymers that then are really the underpinnings for most of the pathology associated with sickle cell disease. So the globin polymerizes, the cells become stiff, there's membrane damage, hemolysis, and vascular damage from that. And what we understand is that hydroxyurea helps ameliorate that polymerization and the downstream effects of that. And the photo on the right is a graphic image of what those polymerized globin proteins look like in a test tube. Okay. So it's been appreciated for a very long time that the higher the fetal hemoglobin, the milder the disease, both in terms of acute symptoms and probably chronic organ dysfunction as well, although certainly most of the data are on acute events, acute illnesses. So thinking about the difference between soluble hemoglobin and polymerized sickle hemoglobin, in the test tube, over 15% of fetal hemoglobin actually inhibits the polymerization of deoxygenated sickle hemoglobin. So unlike hemoglobin A that's simply in the cell or in a test tube, A simply dilutes the sickle globin, thereby reducing the risk of polymerization. The fetal hemoglobin actually inhibits that polymerization through its electrostatic interactions between the fetal and the sickle globin. Now, clinically, again, recognize that high fetal hemoglobin, as I said, is associated with milder disease. So, for example, the extreme phenotypes of people who have compound heterozygous states of sickle on one allele and hereditary persistence of fetal hemoglobin on the other, people with that phenotype have little to no symptoms of sickle cell disease, or people with the Arabic form of sickle cell who have very high fetal hemoglobin levels. So in prospective large clinical studies in the U.S. and in Jamaica, people with higher than 15 to 20% fetal hemoglobin had much fewer clinical complications, overt acute clinical complications of sickle cell disease, although keeping in mind that the amount of fetal hemoglobin per cell is a certain percent, but that cells vary in the amount of fetal hemoglobin. So there is some heterogeneity of cells, and presumably the cells with the higher intracellular concentration of fetal hemoglobin are more stable, again, because of the polymerized sickle hemoglobin reduction, than cells that have less fetal hemoglobin. So there is a biologic heterogeneity. And I'm going to be talking about fetal hemoglobin, which is really an average because you lyse the cells and measure fetal hemoglobin by high-performance liquid chromatography. But some researchers also refer to F cells, which are cells that have high levels of fetal hemoglobin in them. They're very highly correlated, but as I said, I will focus on measuring the measurement of fetal hemoglobin, not F cells. Okay, so hydroxyurea sort of started clinically in 1984 with this groundbreaking report by Platt et al. That sickle cell adults, two sickle cell adults treated with hydroxyurea were noted to have an increase in fetal hemoglobin levels, and that followed from some experimental animal models demonstrating same. Next slide, please. So between 1984 and really the publication of a tremendously important paper on the multi-center trial of hydroxyurea in 1995, this was a randomized trial of hydroxyurea in adults and showed without a doubt that people on the hydroxyurea arm had significantly reduced episodes of painful crisis, so about a 40% reduction per year. They also had significant decreases in acute chest syndrome that's been covered in previous talks on sickle cell, and also in transfusions. And really based on the so-called MSH study, hydroxyurea, which had previously been used for chemotherapy, was approved by the FDA for use for adults with sickle cell disease in 1998. So the indications for clinical use stemming from this trial were reduction of painful crises and or reduction in incidence of or risk of acute chest syndrome. And I'll talk later about, I'm sorry, I'm not quite finished. Thanks. I'll talk later about what the current indications might be for hydroxyurea, but those are the most established and, again, the basis for which the FDA approved its use. So just to remind you that hydroxyurea is an oral agent. It's a once-daily treatment. It's very inexpensive, and it's widely available, and obviously all of those aspects are very positive features. Okay, next slide, please. Thank you. So what is hydroxyurea? Some studies call it hydroxycarbamide, and there's the chemical structure. So its effect on red cell production is understood fairly well, although I think there's some more room to understand how it induces fetal hemoglobin and some of its other effects physiologically. But I'm going to just talk about what we understand is the major function of hydroxyurea. So it's as I mentioned, it was previously used as a chemotherapy. It's a ribonucleotide reductase inhibitor. So it impairs DNA synthesis and causes some transient cell cycle arrest. So this transient toxic effect on red cell precursors results in a sort of daily cycling of toxicity and then recovery phases of the marrow and the erythroid precursors. And in that recovery phase, the red cell progenitors with higher fetal hemoglobin levels are recruited. And so that's what we think is the physiology of fetal hemoglobin induction through a soluble guanylate cyclase activation. So as I mentioned, this is a daily drug and has a short half-life. So these sort of diurnal, if you will, rounds of cell damage and recovery is thought to be really what's responsible, as I mentioned, for the fetal hemoglobin. And so, in fact, the drug needs to be eliminated, mostly through the kidneys, to time this right for correct cycling and recovery. So, for example, people who have renal impairment, they don't eliminate the drug as promptly as otherwise, and therefore have a delayed phase in marrow recovery and may not then have the fetal hemoglobin increase because of that delayed recovery. So this is sort of in hematologic terms referred to as stress erythropoiesis, where this constant recovery has, again, a higher fetal hemoglobin, and certainly has been shown quite some time ago to require a proliferative marrow. And that becomes important later in thinking about whether there are differences between older adults who may have marrow damage secondary to chronic marrow infarct and other effects from sickle cell versus use in children who don't have that, who won't have that effect on marrow usually. Okay, next slide. Okay, so again, how does hydroxyurea work? And this kind of summarizes what we understand of its effect. As I mentioned, the fetal hemoglobin has primarily a red cell effect, both in terms of the polymerization of the sickle globin and the subsequent damage to red cell membrane and hemolysis. There's also a vascular effect, we believe, so there's an increase in available nitric oxide, probably a combination of both decrease in nitric oxide scavenging from lysed red cells and also potentially some effect from as a nitric oxide donor from the drug itself. There's also a decrease in inflammation. If you think back to the dactylitis picture we saw earlier, at least in large part is proposed to be due to a decrease in white blood cells and platelets in the circulation from the hydroxyurea effect on the marrow. So overall, there's less red cell sort of trapping in the microvasculature, clinically decrease in ischemia and necrosis, so that might be manifested by acute chest, vaso-occlusive crises, potentially even stroke, although I'd say that we don't really know about that yet, and splenic infarction. Decrease in the membrane damage and prolonged red cell lifespan, so there's improvement in the anemia and decrease in hemolysis. And also there's a decrease, what we understand to be a decrease in vascular damage and endothelial activation from the red cell and white cell and platelet interactions with the endothelium, less cell adhesion, and as I mentioned before, nitric oxide-mediated vascular tone. So, if we believe all this, and we have, there's some experimental data to support it, and clinical data that's supportive, then the hydroxyurea really approaches sort of most of the underlying pathophysiology of sickle cell disease. Next slide. Okay, so this is a lovely depiction of, in a blood smear from Russell Ware, of the effects of hydroxyurea on sickle cells. So the before and after, left and right respectively, are pretty striking. So on the left you see the classic sickle cells that are sort of needle-like and I suppose resembling sickle cells. And then on hydroxyurea, the same patient, you can see that those effects from sickle cell are largely gone, maybe not completely gone, and I think that's a realistic assessment of clinically how hydroxyurea works. But it's, I think, a very striking depiction of its effect. And so I also listed here are the changes in laboratory changes induced by hydroxyurea, and I put in an asterisk where there's a direct clinical effect from hydroxyurea. So, for example, very importantly, as I mentioned earlier, that anemia is obviously a pervasive issue with sickle cell, and there's an average of about a gram increase in hemoglobin, presumably from less hemolysis and stabilization, as I described earlier. And now that's particularly important for the well-being of people, and also we suspect that the improved hemoglobin may also affect improved growth for children. There's an increase in what's called MCV, or mean corpuscular volume of the red cell. We don't really know what that means as far clinically, hence the lack of asterisk, but it's a good biologic marker, like fetal hemoglobin, of the effect of hydroxyurea on sickle cell, both in terms of amount of response, which I'll talk about later, as well as potential adherence issues. And then, as I mentioned earlier, the sort of the hallmark biomarker of fetal hemoglobin and average increases by considerable extent in children and to a large extent in adults as well. And that percent is not the percent of the total, but it's a gram percent. So, for example, if the average child with sickle cell disease has a fetal hemoglobin of about 8%. So it goes with hydroxyurea on average to 18 or 20%. There's also, as I mentioned earlier, a decrease in white blood cells and platelets, and that probably has a positive effect in reducing vascular activation, endothelial activation, and inflammation. There's a decrease in a neutrophil count, and I'll get to that later. And probably because of almost certainly reduced hemolysis, then reflected in the reduction in reticulocyte count and the lactic dehydrogenase, or LDH levels. Okay, so in 2008, NIH produced a consensus report about hydroxyurea, and the quote is pretty striking, that the compelling benefits warrant increased adoption of the drug as a frontline therapy in adults with sickle cell disease. Again, thinking about the MSH trial that I mentioned earlier, where a lot of the initial clinical data were derived. At that time, there was a sort of a lukewarm recommendation for children, again, not FDA approved at that time, and still today, which is an issue. I think subsequent to this report, there's been a lot of clinical studies, some of which I'll go into a little bit and mention the potential ameliorative effects of hydroxyurea beyond acute chest and acute painful crises. And so, but this is a reminder to all of us that we don't have newer guidelines. They're federal national guidelines for use of hydroxyurea. Those guidelines are in process of being updated, and they will be welcome when they arrive. So now there's considerable provider-to-provider variation and center-to-center variation in the use of hydroxyurea absent those guidelines. Okay, next slide, please. Okay, more recently, there have been a couple of reports, this one and then in the next slide, which I'll get to, that are really very striking regarding the impact of hydroxyurea on sickle cell disease-associated mortality in adults. So this is a study done in Greece of people who got hydroxyurea over at least a 10-year period, and you can see that the mortality rates with hydroxyurea are considerably reduced compared to those not receiving hydroxyurea, both for people with hemoglobin SS, which is the majority of the people in the study, and also for people with S-beta 0 thalassemia. And just to note that people who, in that study, this was sort of a single-site observation, that people who had been given hydroxyurea initially were those who had more complications. So in fact, so when we think about heterogeneity of severity of sickle cell disease, people who were originally more severe actually ended up doing better mortality-wise than people who were, at the time of the beginning of the study, were less severe. So I think that's very compelling data for use of hydroxyurea. Okay, and also thinking back to the initial curves that we're expecting that hydroxyurea has a measurable impact in mortality for people with sickle cell. Okay, next slide, please. And then here, based on the MSH US data, looking at, on the y-axis, cumulative event rate. So that's so the higher the rate, that reflects higher severe clinical complications. So people who were taking hydroxyurea for more than 15 years, all the way over on the right, had far fewer time-dependent complications than people who had never taken hydroxyurea, and you can see that the longer people took it, the better. Okay. Next slide. Okay, and so this is a slide borrowed from Russell Ware that then, based on the MSH early studies on adults, rapidly by clinical research standards, maybe not by patient standards, but started a series of largely NHLBI-funded clinical studies using hydroxyurea in children, initially sort of school-age children, and more recently then these baby hug and HUSOF, so infants with sickle cell disease. And I'll talk about these findings, but I think that this is helpful to understand sort of where hydroxyurea started and where we are actually as of 2011 with respect to use of very young children. Okay, next slide. Okay, so again, this is a study done, again, by Russell Ware, so-called hug kids. So children were not very young. They were sort of school age when they started. But you can see on the left that children, as I mentioned earlier, have a robust, almost all have a robust induction of fetal hemoglobin for about, on average, 10 or 12%. And so thinking about the threshold level of fetal hemoglobin for milder disease over 15 to 20%, you could see that most, although not all, of the children were on the hydroxyurea had levels that were indeed over that threshold of 15%. And that in that particular study, over 80% of the children responded. There was some mild toxicity and some drop-off, but overall, almost all responded. And then subsequent to this study in children, there were later studies published recently that documented improved quality of life for children with sickle cell disease and also decreased costs of medical care, which I think are, beyond fetal hemoglobin, are both very important assessments of improved disease course with hydroxyurea. Next slide. Okay, and then an important paper published not long after looking at the effects of hydroxyurea over time, that those effects have been sustained, that it wasn't just a transient impact on hemoglobin and fetal hemoglobin, the other measures that were mentioned. And there was also some analysis of people with hemoglobin SC who have overall a much more muted response to hydroxyurea than people with hemoglobin SS or S-beta-0 thalassemia. Okay, next slide. Okay, so overall, what can we say about the effect of hydroxyurea on adults and children? And when I say adults, these are adults who started on hydroxyurea during adulthood. We don't really know what happens for people who were children, young children in particular, started on hydroxyurea, and how their lives have gone, their disease has progressed. So this is really looking at two separate populations. And so if you look at the impact on adults and children, in fact, it's quite similar. Probably, although the reports are a little bit mixed, but probably have a better increase in fetal hemoglobin in children than adults. But again, that's variable. Both have a decrease in acute crises and hospitalization. And a theme that I will start mentioning is the underutilization of hydroxyurea both in adult and pediatric populations. And I'll have more to say about that in a moment. So we don't really know if there are differences in toxicity between adults and children with sickle cell disease on hydroxyurea. Those toxicities may depend on marrow reserve, as I mentioned earlier. There may be some other time-dependent differences in marrow and fetal hemoglobin response and erythroid progenitor response. Certainly, we don't know about some of the other long-term toxicities. If there are differences between children and adults with respect to other largely theoretical concerns, although some real, around carcinogenicity or fertility. We just don't know. And again, I'll address the potential toxicities in a moment, but again, we don't know if there's differences between adults and children. But I think that the predominant consensus amongst pediatric hematologists, and I'm speaking as a pediatric hematologist, not as an adult hematologist, is that once disease and organ disease occurs, in fact, I think studies have shown it's very difficult to reverse with respect to spleen and kidney function, but that prevention should be the mainstay of our approach to use of hydroxyurea, and therefore earlier initiation of hydroxyurea is going to probably be more beneficial. Okay, so what's the standard clinical approach? Now, I don't have a slide on the clinical indications for hydroxyurea, again, because there's variability. There's certainly agreement about people with indications for hydroxyurea for people who have recurrent pain and even one episode of acute chest syndrome, given its high rate of recurrence. And then variability with respect to people who have low hemoglobin, a lot of sort of chronic highly hemolytic state, other indications, potentially prevention of priapism. I mean, we don't have or chronic fatigue or poor growth. We don't have guidelines for that. Okay, but the dosage, as I mentioned earlier, is once a day, and with a range of dosing. Practitioners have sort of two endpoints, I'd say, for hydroxyurea dosing, starting at a lower dose and potentially going higher. One is to clinical efficacy as defined by, do people feel better on taking the drug, and also fewer hospital acute visits, either ER visits or hospitalizations, or to a maximum tolerated dose, as usually defined by neutrophil count, absolute neutrophil count. And that's, again, I think a consensus that would be great to have, but is lacking. Certainly, most children tolerate a dose of at least 20 to 25 milligrams per kilogram per day. Some people are very sensitive to hydroxyurea, and so their white blood count or platelet count or even hemoglobin can drop with those kind of doses and really require a lower dose. But certainly, most tolerate that dose. And actually, the paper that I cited earlier by Zimmerman et al. In 2004 demonstrated that higher doses are associated with higher fetal hemoglobin levels. So I think many of us have the philosophy, although not evidence-based, that to get the full benefits from hydroxyurea, it really is worth pushing to the MTD, or maximum tolerated dose. The effects of hydroxyurea are not immediate. The standard statement is it takes 6 months to work. I can tell you anecdotally, and this has not been published, children on hydroxyurea often have an improved fetal hemoglobin and even hemoglobin levels within a month or two of treatment. But again, that's not been systematically assessed. One paper has looked at the increase in the size of reticulocytes as an early indicator of hydroxyurea effect, and the toxicity, as I mentioned, will be described in a moment. And again, there is not a uniform dosing or even target for dosing between centers or between pediatricians and individual practitioners. And I would like to say that having standardized indications and dosing and target toxicity for threshold to moderate dose would be very, very helpful for looking population-based or at least multi-center-based at the effect of hydroxyurea. Okay. So when hydroxyurea works, and this is actually taken from a child with sickle cell disease from our own clinic at Columbia. Child in the 3 years before hydroxyurea had 30 admissions for pain, had very low fetal hemoglobin, low hemoglobin, and managed blood transfusions. And after 1 year on hydroxyurea, was not admitted, did not miss days of school, and had no transfusions. And you can see the fetal hemoglobin level went from about 2% to 15, 16%. The hemoglobin improved modestly, as well as the other parameters that I mentioned, the MCV white count, reticulocyte count. Another potential indication for hydroxyurea would be people who have chronic hypoxemia, and again, not proven but suspected that there may be some positive effect of hydroxyurea on that. Okay. So the other measurable effects of hydroxyurea, this is a study done on children after 1 year of hydroxyurea. This is looking at their transcranial Doppler, which is a measure of flow velocities in children with sickle cell. Lower flow is associated with a is better. Higher flow is associated with increased risk of stroke. And so after 1 year, there was almost universal decrease in the TCD flow velocities in children on hydroxyurea. We don't know if hydroxyurea reduces the risk of stroke or silent infarct as sort of primary protection for vasculopathy and stroke. There has been a study looking at use of hydroxyurea for secondary prevention, and that study has not been favorable for use of hydroxyurea. So again, we may be needing to use hydroxyurea. The hope is that it would be used for prevention of the cerebral vasculopathy, because once that occurs, I think that it's very challenging to manage for hydroxyurea and even for chronic transfusion, which is our alternate therapy. Okay, thank you. So in very young children, these are 2 studies looking at children you can see very, very young, about a year of age, and then treating for 2 years. And you can see that children maintained their fetal hemoglobin levels so that it did not experience the age-dependent drop in fetal hemoglobin that one normally sees in sickle cell, and that there's evidence that, again, if started early, that there can be recovered splenic function with early use of hydroxyurea. Next slide. And then most recently, this baby hug study looking at very young children, average age was about 13 months, that they had treated for 2 years. They had really quite substantial decreases in dactylitis, pain, transfusions, acute chest syndrome, and no obvious toxicity with respect to growth or development over those 2 years. And so the interpretation of this very important study is that hydroxyurea may be safe for very young children and could be considered as early treatment. And I use the language carefully because, of course, we don't know for sure. We do know that silent infarcts and strokes happen very early on in a child's life with sickle cell with very high rates, and we don't know if that's, again, the effect of hydroxyurea on that. But I think the trend, thanks to this important study, will be to, at least for children with acute severe complications, to consider hydroxyurea at ever earlier levels. Okay. So, as I mentioned briefly, there's a tremendous range of, in the response to hydroxyurea as measured by fetal hemoglobin, certainly also the fetal hemoglobin is really a biomarker. There's also a range in response clinically. This is true for adults as well. And here I think is very clearly depicted the distribution of fetal hemoglobin. I guess the numbers are omitted at the bottom. But anyway, the distribution of hydroxyurea-induced fetal hemoglobin in children from a single site, so that with a uniform approach to dosing. Next slide. So we'd certainly like to understand that heterogeneity and the response to hydroxyurea. There's a variable fetal hemoglobin induction, and that's a heritable trait, has been shown looking at siblings. Looking at a variety of clinical and laboratory parameters, I think quite consistently the best predictor of fetal hemoglobin response to hydroxyurea are, number 1, dose of hydroxyurea, and number 2, the higher baseline fetal hemoglobin. So people who have a fetal hemoglobin, children anyway, let's say they start at about 12%, so they're in the higher echelons, they're more likely to go over the 20% mark with hydroxyurea, and similarly people in the very low levels to start with, let's say 2 to 5% have a response, but more muted, although there are exceptions, and some people with very low levels do get to be very high levels from hydroxyurea. There's a genetic variability to the both baseline fetal hemoglobin and hydroxyurea-induced fetal hemoglobin, and I think that's a very interesting and evolving story with a lot of attention to a negative regulator of fetal hemoglobin expression, namely BCL11A. There's also some variability in hydroxyurea metabolism, and so that may affect, certainly affects response to hydroxyurea. And then, as I mentioned earlier, that since there'll be variability with respect to marrow capacity, and drug elimination. Interestingly, as I mentioned, the Arab Indian type of sickle cell, people who start out with fetal hemoglobin that is much higher than those that we see from African or African American populations, that those people treated with hydroxyurea had in fact improved fetal hemoglobin and decreased clinical severity, even at their higher levels. So there did not seem to be a ceiling effect for fetal hemoglobin based on those in that report. But the clinical correlation with fetal hemoglobin is good, but not well established. Again, we think it's higher is better, but that has not been directly demonstrated, except in adults with very, very low fetal hemoglobins. Okay, next slide. So unlike other disease markers like hemoglobin A1C for diabetes, the fetal hemoglobin response may need to be individualized for a person, and we sort of use the term personal best, that regardless of where your fetal hemoglobin starts, with hydroxyurea induction, it's probably better, and how much better it will be is, as I showed you earlier, it varies, but nonetheless, I think one of the strategies that we use for encouraging adherence to hydroxyurea is to review with families the fetal hemoglobin responses, because clearly when people, for whatever reasons, decrease their use of hydroxyurea, one can clearly demonstrate a decrease in their levels. And then, as I mentioned, the other sickle types, so we have much less data on people with hemoglobin SC, SE, SD. Certainly, hemoglobin SC is a very important variant of sickle cell in the U.S., at least from newborn screening. It's about 30% of people with sickle cell disease will have hemoglobin SC. And as I mentioned, the effects are really quite muted, and just clinically, the effects of hemoglobin, of hydroxyurea on hemoglobin SC is variable. There's modest increases in fetal hemoglobin in SC. But as this early New England Journal article stated, I think quite elegantly, that even small increases in fetal hemoglobin appears to improve the clinical status. So even for people who have low baseline fetal hemoglobins and only a modest impact from hydroxyurea, that appears to that may be helpful, and people again report feeling better even if they have only modest improvements. And then beyond fetal hemoglobin, there's a whole other dimension of hydroxyurea response. As I mentioned earlier, the white blood cells, nitric oxide, and we need ways to really quantitate those effects on the disease progression and with impact and importance for dosing. Okay, so as I mentioned, hemoglobin SC and others, there's an increase in fetal hemoglobin and little or no increase in hemoglobin, and again, a variable but modest impact on acute symptoms, and certainly concerns about hyperviscosity. So people with hemoglobin SC already start off with higher hemoglobins than people with SS overall, and hyperviscosity is a problem for other complications of sickle cell retinopathy, avascular necrosis of hips, and other long bones. And so there's some concern and reluctance to push doses of hydroxyurea or even introduce hydroxyurea for people with hemoglobin SC who already start off with a hemoglobin over 10 or 12. And there are no standards, no national guidelines for hydroxyurea in these populations, and despite the importance of that, and there's just been a relative paucity of studies done on that for practical reasons. Next slide. Okay, so the toxicity of hydroxyurea, and I'm going to wrap up. As I mentioned, there's a dose-dependent decrease in white blood cell count, and probably beneficial in terms of effect on disease, but none of us like to introduce neutropenia and potentially risk for infections, so there's a balance there. There's some gastrointestinal, mostly nausea, some hair thinning, skin and or nail hyperpigmentation. And I would have to say, from a clinician's perspective, that those are all pretty mild and addressable. The bigger issues are the teratogenicity, so fetal susceptibility, hydroxyurea. There's not been a lot of data, really only one report that didn't have any overt teratogenic effect, but the numbers are small, and many of the young women who had exposed pregnancies, in fact, chose to terminate. So we really don't have, we don't know what this fetal susceptibility is, but certainly I think good clinical practice would indicate that one or more measures of birth control would be advisable. The question of fertility is an issue, and I think we don't really have a handle on fertility and sperm count for people with sickle cell before hydroxyurea or after, only really one report. And so that's a concern that has to be raised with families and bothers them a lot, understandably, but we don't really know what that means. And then for the carcinogenicity, for the sake of time, I'll just say that there have not been reported increased incidence of cancers on people who have had now a couple of decades worth of hydroxyurea, but because of its, probably the concern is linked to its previous use in people with chronic leukemia, and also that there's some mixed evidence for some laboratory effects on DNA stability. And as I mentioned earlier, the potential for young children and developing brains in particular, although to be balanced by disease effects. Okay, next. So I think in summary, if one considers sickle cell to be an episodic but otherwise benign disorder, which I think a lot of people view sickle cell that way, both families and perhaps even some practitioners, the risks of hydroxyurea may be scary. But if you understand that hydroxyurea is a chronic disease leading to multi-organ failure with complications and damage beginning during childhood, I think one has to then take a very different perspective that the risks, for most people, are outweighed by its benefits. Next slide, please. So I think there are limits to its clinical benefit. It's certainly not a panacea. There are people who hyporespond or have very, very, very sensitive. The marrows are very sensitive to its toxic effects and really can't take it. We don't know the extent of organ preservation or reversal of damage. And then, as I mentioned throughout this talk, we don't know enough about what the clinical indications are. There's complications, sickle phenotypes, age limits, toxicity, and then the issues of barriers to use, and I'll address that in the next slide. So both for providers and for patients or families, there have been demonstrated barriers to use on both sides of the white coat, I'd say. And if you look at the slide, you can see that the concerns, in fact, are in sync. So therapeutic nihilism, the concern about frequent visits where we monitor neutrophil count and other toxicities, concerns about pregnancy exposure and long-term, as I mentioned, the fertility issue, and I think, again, on both sides of the white coat, incomplete recognition of benefits, even based on what we know today. Next slide. This is from a study done, an unpublished study that was presented, and thanks to Suzette Oyeko at Einstein, a survey of multi-site study of caregivers, so mostly parents, with their understanding about hydroxyurea. And this just illustrates that only 2/3 of these parents had heard about hydroxyurea. Fewer than 50% knew about its clinical impact, and only a very small number understood about the fetal hemoglobin. So we have a long way to go in helping people understand its effects. Next slide. So there are many questions raised about hydroxyurea, and I'll go through this quickly to help leave time for questions, and many that I have mentioned, including its long-term impact, starting in young children, the role in management of prevention of some specific disease complications, the prediction of individual response to hydroxyurea, which would be a wonderful thing to have, but we don't have that at this point, and the optimal dosing, whether to push to neutrophil toxicity, even the question of once daily or other dosing schedules. Next slide. As I mentioned, the impact on other sickle cell disease variants, combination with other drugs, such as decitabine or other chromatin modulators. And then are there some people who are better off with other treatments? Of course, the options being terribly limited, and then certainly what its impact might be internationally, where there are in areas of the world where there is very high rates of sickle cell disease. Next question. So here's a list, sort of a wish list of uses of hydroxyurea for prevention of disease morbidities, and the focus being renal, pulmonary, and certainly central nervous system. I mentioned earlier. Next slide, please. There's some open active studies as per clinicaltrials.gov. Just to give you sort of a snapshot of these are trials that are actively recruiting, looking at inflammatory responses, the long-term effects of hydroxyurea in children, a lot of brain-focused studies, brain injury, prevention of brain injury and imaging, and the transcranial Dopplers that I mentioned, and then not easy and highly toxic experimental treatments for those people who, for various reasons, cannot use hydroxyurea. Okay. I think I have one last slide. So in summary, hydroxyurea continues to have a remarkable impact on disease, both morbidity and mortality. The indications for its use are increasing, although, again, we lack national guidelines. Uses in younger children is growing, but probably needs to increase. And a series of questions about optimizing its impact. And then I do have one last slide. Okay, so what is this is a practical question. What are the other clinical options for people with sickle cell disease? And, those options are limited. So is this still an option? And I have to say that given, I think, the compelling clinical data, I think that clinicians and families need to ask the question, maybe not only, should me or my child be on hydroxyurea, but why not hydroxyurea? Frame it that way. Obviously, stem cell bone marrow transplant is still experimental and limited and has some significant toxicities and mortality rates. Ditto with some of the other drugs, and the other experimental therapies are not here. And so, I'd like to convey my enthusiasm for hydroxyurea, and I'd be happy to answer questions. Thank you very much.
Wonderful. Thank you so much, Dr. Green. That was really wonderful. So we're now going to open the line for questions if anyone has them. Just as a reminder, please remember to unmute your phone by pressing *6 when you need to speak. And if you have a question, we'd like you to raise your hand electronically, and your names will be called in the order received. Unfortunately, we only have this line scheduled for about another 5 or 6 minutes, so I'm going to need to end this session when we reach that point. And if you do have further questions for the panel or for our speaker, for Dr. Green, if you send your questions to Shay at spope@cdc.gov, we'll be sure to forward those on to Dr. Green. So it looks like we have a question from Jonathan Stiles. So please remember, press *6 before you start speaking. Jonathan? Jonathan, we can't hear you if you're speaking, so press *6, or maybe you have your own phone on mute.
Can you hear me now?
Yeah, perfect.
Oh, okay, yes. I just wondered, apart from the hydroxyurea, do you know of any medicinal plants that have been used in the past to, support sickle cell disease patients?
I'm going to give you a short answer, and the answer is not in a systematic way, no. That doesn't mean that there aren't other medicines out there, but not in a randomized trial kind of setting, no.
I see. Thank you.
Thank you.
Thank you. Our next question is from Jim Nichols. So if you'll press *6. We can't hear you, Jim, if you're there. You might have your phone on mute or press *. Oh, I think.
You hear me?
Yes.
Hello?
Yes.
Okay. I'm Zara, the initial BI fellow, clinical fellow. I wanted to know what's your experience using hydroxyurea in patients with leg ulcers. Because a lot of hematologists don't use it, like if someone has history of leg ulcers or they have current ulcers.
Right. That's an important question. So I know that the small reports have been mixed on it. I have to say that as a pediatric hematologist, we don't see leg ulcers, so I don't have any clinical experience with that, and I'd have to refer you to an adult colleague. But I think that there's some concerns about impaired healing, so I think it's a mixed picture, and I'd be happy to be corrected by one of my adult colleagues on that answer.
Okay, because I read a review. It was a systematic review from Sophie Lanscombe from Hopkins, and then she was, just said the one line that studies don't show the association, but then there was no paper. Like I couldn't find any studies specifically looking at this. So I thought maybe a study, or you have seen a study or paper.
If you send me the email through Shay, I'd be happy to see what I can provide you.
Okay. All right. Thanks.
Okay, I don't think we have anybody else who's clicked in on the computer, but if someone would like to ask a question just via the phone, if you press *6, and you can identify yourself with your name and ask Dr. Green any questions.
My name is Judith Frank, and I was wondering...
This is Mary Lamar. I have a question.
I'm going to let Judith Frank speak first. That's the first voice I heard, please.
Thank you. Just very briefly, clinical things that you use. What kind of numbers do you use when you titrate the dosing in terms of white cell count, neutrophil, ANC, or platelet counts? When would you either decrease your dose or change your dose?
Right. That's a very important question. I think the clinical trials have used initially about an ANC of about 2,000, more recently about 1,500, again, reflecting, I think, a more aggressive perspective. And, again, no national standards. I can tell you from personal experience, we argue about this, but I think we are settled more on the 1,500, really because, in fact, there have not been reports of children or adults, as far as I know, with hydroxyurea-induced neutropenia who then became clinically ill from it. And if there are people with different experiences, again, I would be very grateful to have people contact me with those experiences. So I think the question, the issue is largely theoretical, and as one of my pediatric oncology colleagues quipped recently, we give chemotherapy for people who have an ANC of 1,000. So why are you so nervous? So anyway, I think, again, it's sort of philosophical about at this point, the theoretical risk of infection, neutropenia, susceptibility to infection versus improved clinical effect. And I think we don't have an absolute answer to that.
Okay, thank you.
Sure.
Thank you. I'm sorry. Unfortunately, we're going to be cut off in about 1 minute. And so if anyone has further questions for Dr. Green, again, if you will email Shay at spope@cdc.gov with your questions, we'll make sure we send those on to Dr. Green and get a response for you. So this concludes our series of webinars for 2011. We won't be having one in November or December because of the holidays, but we will begin again back in 2012 on Thursday, January 26th. The topic that day is going to be transitional care for sickle cell disease patients, pediatric to adult. And also be on the lookout, Shape Hope is going to be sending an online survey request to those that have been listening into the webinars. It will truly take you 2 or 3 minutes. So if you can respond to those surveys, we'd really appreciate it. So, and just also as a reminder that the webinars, almost all of our webinars are available for viewing and listening at www.scinfo.org, and it's under the webinars toolbar. So I just want to say thank you so much to Dr. Nancy Green. This has been a wonderful presentation. There were a lot of people watching and listening in today. So thank you all for participating, and we will see you again in 2012. Thanks very much.
Thank you.
Bye-bye.
Bye-bye.